Hi, good afternoon, good evening, no matter where, depends on where you are. Thank you for joining this special edition of webcasts by Galderma. I'm Stephen Liu, I'm a plastic surgeon in Sydney. Thank you for tuning in. Today I want to talk to you about SubQ, Restylane SubQ. The main reason for this webcast is we're trying to debunk some of the myth, some of the misconception that some of you may have overheard in the injectors community. Let me give you a little bit of a background of Restylane SubQ. It's been available in Australia since 2006, and I have been one of the few fortunate ones to be involved in using the product, in learning about the product since 2006. So cumulatively, I've been using this product for about 7 years. Tonight I'm going to share with you what I know about the product and how I've been using it in my clinical practice on a day-to-day practice. So it is interesting because in the last few years there seems to be some fear among some of you of using Restylane SubQ. And some of the fear has been that it causes lumps, the product migrates, it's prone to infection, and causes swelling. Historically, from my experience, this does not seem to be the case. So as I've mentioned, I've been using this product in from end of 2006, and the gentleman who introduced this product to Australia was a plastic surgeon from Italy, Professor Giuseppe Cito, and some of you may have fortunate to have met up with this brilliant individual. So in the last 7 years, I have treated close to about 420 patients. There has been only 3 cases of my personal complications. So some of you who know mathematics, this is fairly small numbers. And what are some of the complications? The first one being product displacement, and I'll show you the case. There has been 2 cases of small nodules formation in the jawline, where the patient will just on passing by mention the 2 small nodules, not truly concerned by it. And I will talk a little bit about why that is so. Of the 420 cases that I've been involved with, majority of the patients, 70% of them, I use Restylane SubQ in the mid-phase, essentially to enhance the cheek. This could be from the lateral cheek or the mid-cheek in some patients who specifically need the augmentation in that region. And 30% of the patient I use it for chin enhancement as well as for jawline rejuvenation or enhancement, and nowhere else. So I want to share with you the technique that has been involved since its introduction in this country. So for the first 2.5 to 3 years, the technique that I've employed were essentially, for the mid-phase, were essentially an intraoral approach by using a large size cannula, essentially because that's what's available in those periods of time, an 18-gauge cannula, which we hardly use nowadays. So it was an intraoral approach, and I love it. And a group of my patients, they still like it today. Why? Well, why do I like it? Because if you think about conceptually, if you want to place a product onto the cheekbone and through the mouth, it is the closest, shortest approach to it. Because it's so close to the bone, you actually place it so deep, you can't go deeper than that. You get less irregularity and less palpability or even visibility of the product, and create a very nice, smooth contour. That's why the patient like it. Not because they like it through the mouth, it's because of the effect of it. But I do accept and understand it is fairly difficult teach, and it has a very steep learning curve, particularly if you are concerned about going through the mouth, because as an aesthetic physician or surgeon, this is something that we try not to get too close to, because it's a perceived invasiveness for this procedure, and perhaps it's considered to be not very clean, and it does take a little bit longer than what you guys or what we get used to now is transcutaneous. But interesting enough, there is still a group of patients even today will actually want to have this approach being used because of the smoothness of the contour. But having been in that particular using particular approach, I feel that if you can use a percutaneous technique, well, there's no reason why we cannot produce the same effect and still place it at the same plane. And tonight I'm going to show you how I do it in my clinical practice. What I want to do now is I want to share with you briefly what we did. In 2006, 2007, here we have an Asian patient, and we mark up the patient as you would have done today with a technique through the skin. So because we're going through the mouth, we need to give them some nerve block, and I routinely in those days use a infraorbital nerve block, almost like going to see a dentist, with some local infiltration. And I also infiltrate the zygomatico-facial nerve just to provide some numbness in the upper cheek region. And then we let it sit, and then we need to create a tunnel intraorally with an 18-gauge needle. So like any cannula, you need to create an opening with a sharp needle. And once again, it was a huge needle, 18-gauge. And then we use an 18-gauge cannula, okay? And in order to create some tracks, some tunnels for us to place the product at the end. So we want to create as many tunnels as possible, like what you see now. Notice that with enough anesthesia, it's actually fairly comfortable procedure. So once I normally made about 5 to 6 tracks, then with the same cannula, I place the product in, and I basically, because the track has been performed, I basically slowly squirt the product into that particular cavity. Okay, so no in particular direction, just staying deep and place the product. And then I mold the cheek in order to get the result that I want. Now I want to show you, I move on to another video. So this is what I have. So this is what I want to show you now. This is something I prepared earlier, a patient who just happened to have an endoscopic mid-parietal facelift, where I make an incision in the mouth using the same cannula to create the tunnel. If we can play that movie again, please. First of all, you can see in your view an infraorbital nerve. You can see the tunnel, and on the bottom of it you can see bone. And at the 12 o'clock, we're just going to play it once more. So you can see on your view the nerve, you can see tunnel and bone, and some of the mid-cheek fat and some of the muscle overlying on the roof. So it's actually a very deep placement of the product. So interestingly, you would have guessed that going through the mouth with saliva, a big cannula, quite a forceful track, you would assume to get a lot of swelling, a lot of pain, a lot of discomfort. Well, in fact, you don't. And if we were to show you the next slide, you will see that during that 2.5 years, I've only had one complication. That is a patient who have a small lump in the corner of the right lower lid due to product displacement. And I'll explain a little bit why. It's because of my technique, and it's non-product related. It is very easy to blame the product, but I think, you know, for an experienced and a professional injector, most of the time we should actually sit back and actually try to actually work out what went wrong. So this patient, as you can see, this was taken at about 3 weeks after injection. She doesn't see this product in week 2, it's only happened in week 3. And this is clearly a subcutaneous, or in this particular case, the product is actually deep to the eyelid skin. Now, how is that possible if you place it so deep right onto the bone and 3 weeks down the track, the product actually gets there? It's not because the product can move. It's simply because the product's been displaced by repetitive, normal physiological motion of the cheek. We smile, we eat, we kiss, that create compression. In this particular case, obviously, in my process of creating the tunnel, I've actually gone a little bit too superficial, pierced through the orbicularis muscle or cheek muscle through the orbicularis muscle. And because of that little gap, even though the product was pulled quite deep on the bone with repetitive motion, contraction, smiling, the product will sometimes being squeezed through that tiny little gap into the pathway of least resistance. In this particular case, just happened to be through that tiny little gap within the muscle, orbicularis muscle, and get into the subcutaneous tissue. Is it the product fault? Absolutely not. It is my technique. So let's move on to what do I do now and what do most of you do now. Well, because of, I guess, it's fairly hard to teach and steep learning curve, and people can't get used to it. In fact, less of popularity, lack of demand. So I have converted into teaching it transcutaneously. My preferred technique is use of cannula, because I believe that particularly for someone who never had this done, you can actually do it gently with such a minimal discomfort. I don't use any blocks anymore, I don't use any creams, I just use a very small amount of local infiltration of the point of entry. And I will show you how much local anesthetic I use. So mid-face, I use 21, sometimes 22 gauge cannula or needle. And same thing with jawline, I use the same 21 and 22 gauge cannula or needle. And there's a reason for using that particular gauge. Of course, you can squeeze through SubQ through a 25 gauge cannula. But I would hopefully, after this webcast, to convince you not to, and there's a scientific reason for it. So since I've changed the technique from intraoral to through the skin, I have 2 minor complications. There are 2 small minor nodules on the jawline very close to the pre-jaw sulcus, where there is porosity of soft tissue. Once again, it is non-product related because it is just simply my technique, placing it inadvertently, not deep, it's just too superficial. It is very easy to inject the jawline coming from an area where it is fairly thick and you stay very deep to the bone and is covered by your skin, your fat and your platysma muscle, and underneath the platysma there is some pre-periosteal or fat just on the bone. But right at the pre-jaw, particularly elderly patient, where there's a transition, out of the sun there's no thick soft tissue from the jaw, all you have is a little bit of soft tissue and a small amount of lower lip depressor. And that's where the 2 cases was, simply because I wasn't, once again, I wasn't consciously enough to place the cannula or needle right deep onto the bone. So it's just another case of technical issue. In the last few years too, I have been referred quite a lot of cases, and I just want to share with you and use this as a discussion point, and perhaps use this as a starting point for some of you who may have some issue with complication of SubQ. So I have 2 cases of recurrent inflammation. What it means is the patient will describe to me is they get some intermittent swelling, and where it resolved with some antibiotic, and after a few weeks, a few months, it came back again. So the patient normally, by the time they see me, they would have had about 3 or 4 courses of antibiotic over a few months. There's no abscess formation, there's no really lumps and bumps to be seen when there's no inflammation. There has been 2 cases of frank cheek abscess that is, presented with a localized classic infection, redness, boggy swelling and tenderness. 2 cases of nodules close to the orbital rim that is visible and palpable and feel quite firm. And 1 case of nodules in the jawline, almost similar to what I have seen myself in my clinical setting, except a little bit larger and is visible. And I'll go through my management and some of the photos of some of these cases later on. I just want now to talk a little bit about science, because I think this is going to be the future. In the next few years, you'll see that people start talking a lot more science of the product. We will hear a lot more about the G prime, the cohesivity, the viscosity, and the compressive force of the product, and why that is important, because that will determine where the product will be and should be used. Restylane SubQ has a extremely high elastic modulus, and you'll be familiar, most of you familiar with the term G prime. It describes the firmness of the product. And Restylane SubQ has a G prime of 1000 kilopascal. Okay, so what does it mean? It means that it is quite a firm product and be able to withstand compression. And in fact, in Australia, Restylane SubQ, and for that matter in a lot of other parts of the world, has the highest G prime among all the other HA. We also know that, when we use product, we want to create a lifting, a sculpting and volumizing of the part of the face that we want to enhance. And you're familiar with the use lifting capacity. And we know that it depends on 2 main factors. It depends mainly on the G prime, as well as how cohesive, how sticky the product is. So we know that the higher the G prime, the higher or the better the lifting capacity. One of the other terms I want to introduce to you is the so-called volume efficiency, and you'll hear a lot more in the next few years. What does that mean? It means that you can just use a certain amount of product and it's efficient in creating a certain volume. Okay, and for instance, if you will not consider a Restylane Vital to be something of a efficient or good volume efficiency, because it's not designed to do so. Whereas Restylane SubQ with a high G prime has a very good, or one of the best volume efficiency among all the HA. So Restylane SubQ, knowing that it has a very, very high G prime, a great volumizer, of course, it's designed to place it deep. And what I mean by deep, it depends on where you're talking about. So the 2 places that's been designed to use is basically the mid-face as well as the jawline. So in this particular area, you want to put it so close to the bone And in some patient who has minimal soft tissue, you want to absolutely sure that you're on the bone. And of course, in some patient with quite a moderate amount of soft tissue, you can get away with it by placing them in the deep subcutaneous plane, but do not, and it is certainly not designed to being placed under the skin or in the skin for that matter, because you will get 100% nodule formation. And once again, if that happens, it is not because of the product, it's because it is being placed in an incorrect plane. So the onus, I think we as an injector needs to take a lot of that responsibility on ourselves in order to use this product accurately, use it the way it's being designed for, so that we can get a maximum result for our patient with minimal, hopefully no complication. Too much sound background. So I coined Restylane SubQ essentially as a soft tissue or soft filler implant in a syringe. It is designed, as you can see later on, for a cheek. It's almost like you're placing a cheek implant via syringe, or chin implant for that matter, because it just creates a very nice outline of the cheek. It is not suitable for superficial placement. Let's now look at this microscopic view. You can see that it is a very uniform particles. There, you can see the particle, and this is Restylane SubQ. So let's recap. It has an elastic modulus of 1000 kPa or G prime, and it has fairly large molecule. As you can see, it has the biggest molecule compared to Restylane, and Restylane Perlane certainly a lot bigger than Restylane Vital and Vital Light and Lip. So it's been designed as a volumizing agent. It needs to be delivered in its natural form. And I'm aware that some clinicians intentionally try to modify that, or try to assume they can modify it by squeezing it through a smaller needle and cannula. My feeling is, of course you can do that, and I mentioned before, you can actually put Restylane SubQ through a 30 gauge needle through a 0.3 ml syringe. Of course you can do it. If you can generate enough pressure, it will squeeze through it. But the fact that you can squeeze through it does not mean that it will behave like a smaller particle Restylane product like Restylane Perlane, Vital and anything, because it just doesn't work that way. You cannot modify the G prime by squeezing through. All you're doing is you are distorting the molecule of the Restylane SubQ. So I just want to emphasize the last point because it is important. And I am certainly aware that some of the complication I'm seeing as a result of some of these presumed modification. So it does not change the G prime, i.e. the product that come out from a 26 gauge needle still has a very high G prime. And as a result, if you think in your mind that you are squeezing through a smaller needle, and you can use it in the skin or superficial subcutaneous tissue, you are going to run the trouble. Just like you're squeezing through a 21 gauge needle and place it subcutaneously or under the skin, you will feel the lump. Just like you will feel it if you squeeze through a 30 gauge needle via a 0.3 ml syringe. And what do you see? You get implant pulpability, you get lumps, and you get bumps, and the patient will come back. So we know that Nasha family is a product with minimal modification of the structure, and because it is low cohesivity, it has a high G prime. So when you squeeze through, a 25 or 26 gauge needle with a small syringe, you will create a high velocity and you will shear the product, you will deform the product, and you will dissociate and fracture and fragment the resilient SubQ into smaller chunks at a greater velocity in distant sites away from the main area of volumization. And that's why I think that if you were to modify this product, sometimes you can see a small pocket of product far away from the area of your main injection site. Why? For the same reason that if you generate so much pressure from the plunger, from the end of the tip of your needle, and that small fragment squeezed through from the main bulk, it will shoot through with such an intense velocity. It will be displaced far away, and that's why sometimes the patient come back and create a lump. It's not because of migration. It's just once again because of what we've been trying to be too smart and trying to modify the product. Let's go on to the complication that I've seen. So what have I done with it? The two cases of recurrent inflammation. Sorry. I'm so sorry. I'm going to skip through. That will come back to that later. Let's have a look at some of the cases that you will see. You will see on your screen a patient with abscess. It's an unfortunate lady who had a abscess that was ignored even by some specialists simply because they didn't recognize there was actually discharging, the pus coming out. So whenever you have pus, you will want to drain this. So this was this patient who has this pus coming out that required to be drained surgically. And this was the next case where the patient presented with recurrent infection where the swelling is coming up. We eventually have to resort to open drainage because despite the fact that we drain it with needle, it just keeps accumulating. It is important to act fairly quickly, and if you can't treat this yourself, I would suggest you refer to someone fairly quickly, simply because when you get such an intense reaction, it eats away a lot of the subcutaneous fat the longer you leave them. So we want to reduce minimal deficit even after we drain them. So let's have a look at some of the complication that I am seeing now. Okay, if we can. So we have two cases of recurrent inflammation. So in the first case, I have to just put the patient on oral antibiotic, and the type of antibiotic I use are fairly consistent. I tend to use Keflex or oral dicloxacillin, 500 milligram, 4 times a day for about 2 weeks. And I also add ciprofloxacin to cover some of the potential gram-negative. And I use 500 milligram twice a day for about 2 weeks. In some patients where the infection is not responding, I will sometimes add Zithromax, which is a form of macrolide antibiotic. I cannot remember the dose on top of my hand, but you can certainly find it in the MIMS. Once again for about 2 weeks. And then once I got that control, I will high lace them and I will continue the antibiotic for another 2 weeks. In case number 2, I actually have to resort to open drainage surgically just to clean it out and continue the antibiotic. In the 2 cases of cheek abscess, it was fairly straightforward. You just have to go in and do, most of the time you can help it, an intraoral incision to drain it, to really flush it out. And sometimes I actually leave the wound completely open. and of course continue the antibiotic. 2 cases of nodules close to the orbital rim. Now it's interesting, these are the patients that were sent to me because it was felt they are resistant to hyaluronidase. Now when you have a nodule formation, particularly if this is 6 to 7 weeks or 2 months down the track, the body forms a hard fibrous nodules around it. And if you just place hyalase in the surrounding area, because of the dense fibrous tissue encapsulating the hyaluronic acid, it's not going to penetrate through that thick capsule. So in those cases, it is important to actually put a fairly large needle under some topical, some local anesthetic, and I tend to use an 18 gauge needle, go straight down there, aspirate it with 1 ml syringe, and sometimes squeeze the product out, and only then I place a little bit of hyalase within the lesion, and that's to absorb it. And you'll find that that tends to dissolve the problem in 100% of the cases. So that is a good tip to remember. If you feel a nodule is not infective, don't be too afraid to clean the skin and stabilize it with your finger, and just pinpoint accuracy, put a sharp needle through it and aspirate it, and then or squeeze the product out and then hyalase it. And there's 1 case of large nodule, once again, aspirate it as what I've mentioned before and hyalase it. So these are some of the cases of mine that, you know, some of you would have seen it before, a 30-year-old wanting a bigger chick, and you can certainly create it with a minimal volume of product. These are more classical patients in their 30 to 40 where they show some mild mid-cheek volume deficit. You can certainly create a beautiful cheek, a very soft, very smooth looking sculpted cheek with a small volume of product. These are the classic where they have a severe volume deficiency. You can enhance them, you can create a wow factor with just a correct placement of product. And this particular patient, all she needed was just a 1.5 ml on each side. And once again, even a thin patient like this, if you place it deep, you can create a very nice product result. And then 70-year-old, once again, you know, the older the patient, I tend to use less product because they don't need so much product to actually make them look good for their particular age. And some of the other cases I do is patient like this with a contour problem. She has the so-called witch's chin. So in this particular case, we want to relax the chin with toxin, and then once we've done that, we want to place a product not in the chin itself, but just along the side of the chin in order to smooth out, to reduce that concavity in that particular region, as you have seen here. And chin enhancement is one of the other area where the Restylane SubQ works very well, because the chin pad in particular is a very stiff and very firm area because of the thick and fibrous mentalis muscle. So you do need something that has a high G prime in order to create the projection that you like for that patient. So if you look at it now, you can see the degree of projection that we managed to create. So in summary, Restylane SubQ is highly volume efficient product because of its G prime. It is ideal for sculpting the cheek, chin and jawline. It is not designed for you to use it in the tear trough. It is not designed for you to use it in the nasolabial fold, or to decant it through a small syringe for use it in the skin. It just, you can do it, but you're going to run into problem with it for the reason that I have described before. To me, because of its volume efficiency and its ability to shape the midface, it is best seen in patients who have a slightly thicker and heavier soft tissue, where you know in order to create the shape, to create the volume and create the lifting, you do need something with a higher G prime in order to overcome the heaviness of a soft tissue. So for SubQ to work effectively, it needs to be delivered with a suitable size cannula and needles, 21 gauge or even 22 gauge cannula. It needs to be placed deep with adequate soft tissue coverage, and I've always stressed that you want to do things slowly and gentle and precise. Even with the cannula, you can inadvertently create a track when you introduce the cannula to area where you may not necessarily want the product, because once the product's in there, when you start molding them, it will be shifted into that area. So please place it, deep. So it is now, I just want to show you the example, this patient that we're going to treat tonight. She is a 42-year-old healthy young lady who has background history of severe acne. As a result, there's a lot of scarring. And as you can see, it doesn't, when I show the patient, I'm going to demonstrate to you the soft tissue is fairly heavy set. So if you, on first glance, you will notice that she has a fairly square trapezoid type of facial shape. And without even asking the question, just looking at photo, you can almost, guess that she probably used her masseter muscle a lot. And this has certainly been confirmed with the patient on questioning. The other thing that's obvious is you see that there is a fairly obvious tear trough formation, as well as an infraorbital hollow. And I'm not sure whether you can appreciate there is also a bit of flattening of the midface, more so on the right than the left, and I'll clarify it and I'll show you a little bit more when we see the patient live. It is important when you treat this sort of patient, mid-face, you need to actually talk to a little bit about the patient, because they will, while they are going to get a very nice sculpted cheek, what you also need to warn the patient is, suddenly with a nice cheek, they will suddenly focus all the attention to the tear trough. And unless you actually consult the patient, telling them that, you will know this is also a problem, they will of course feel that it is the product causing the hollowing of the tear trough. So in this case, I would normally tell the patient that both the cheek and the tear trough needs to be treated, and in an ideal world, I would treat them at the same time. If you decided not to treat the tear trough for whatever reason, it is important at least in your consultation mention that, so that the patient's aware this is another area that needs to be looked at. So I'm now going to get the patient to come in, and while you are there on your screen, you will see that there are the oblique view of the patient. You see the right and left oblique view. Okay. So now I want to do a thorough, brisk assessment of this patient. I'm just going to have a pen. So this is Vanessa. Say hello to everyone, Vanessa.
Hi.
So Vanessa is a healthy 42-year-old lady. If we can bring the camera in a little bit more, just zoom in. So Vanessa, what I want you to do is look, just concentrate. So if we can zoom in as much as possible, please. That's it, perfect. Okay. So Vanessa is very healthy. Vanessa does not have any background autoimmune condition or anything. So if we can just focus on this now, just turn for me. If we can just zoom in, please just concentrate in this area as much as you can. I'm not sure whether you can appreciate, she has the effect of a teenage acne scarring. You can pan in even more. Okay, so you can see there are some scarring from the previous acne scarring. Okay, look around there for me. All right, so come back a little bit more now, camera. So on first look, we have commented that she does have some acne scarring. Just relax for me. Just concentrate now, Vanessa, into that camera for me. Just keep focusing on the camera. If you can zoom in a bit more so that the cutoff point is at the chin, and show me a bit of forehead now. No, just, sorry, you have to pan out. Show the whole face, but from the hairline to the chin. That's it. Okay. All right. So first thing is, we talk about the facial shape, and you can see she has some fairly deep resting line on the forehead that will require attention with botulinum toxin. She has a very good eyebrow shape. She has, in fact, if there's anything, she has quite a prominent temporalis muscle. There's no concavity there. Moving down to the middle third, which is what we're going to focus on. Let's zoom in a bit more now. Just concentrate between the eye and the top lip. Let's get you zoom in more. Bit more. Okay. All right. I just need to see both sides of the face. Okay, zoom in a bit more now. Okay, perfect. So you can see, just relax on your lip now. Good. You can close your eyes now if you want to. Just close your eyes, relax on your lip. Okay, just open your eyes now gently. You can see, first of all, there's tear trough on both sides, worse on the right than the left. And I'm not sure whether you can appreciate, see, certainly a lot flatter on the right cheek than the left. You can almost certainly be sure she's lying on the right hand side. Okay. All right?
Yes, I do.
Yeah. So just relax now. So, and then moving down to the lower part of the face, we've mentioned about the hypertrophy and the hyperactivities on the masseter muscle, and if we were to get Vanessa to confirm, she does in fact clench her teeth significantly. And once again, if you look at it, you know that it's worse on the right side than the left. And apart from that, you know, she has a beautiful jawline, okay? And she has a fairly, you know, it's a quite an aesthetically ideal lip with a nice cheek outline, and a fairly good proportion to her cheek, except with a tiny bit of some shadowing in the oral commissure, which we will talk about in a different session. Now, just look at me a little bit now. Okay, you can zoom up a little bit more now. Zoom out a little bit more, please. We need to zoom out a little bit more. Okay, let's get it focused. Okay, I just need you to concentrate between the eye and the lip. Okay. All right. So just concentrate. So I'm going to, this is how I mark the patient. I like to just draw some guideline, and this just happened to be what we call a Hindra line. Okay, on both sides. Sorry, I might just block your view. So now you can see, just look into the camera now. And then we know that there is a volume deficit here. That's why it's fairly flat. It's not as bad here. The next thing I like to do is I tend to wanting to look at the patient in an oblique view. Just turn towards me and shift the camera so we can see this, please. Where my finger is. Good. Okay. So you can see that this is almost a straight line, and it will be nice to create a bit of a gentle curve for her, just like this. Okay. So that's how I'm going to decide where I'm going to replace the volume, but also to enhance the cheek a little bit. Okay. So this is where, look straight into the camera now. Okay. The other good tip to use is get the patient, just look at the camera. Okay. Can we show both sides of the cheek, please? Okay, and pan in a bit more. Okay, that's it. It's good. Okay. So gentle smile for me in the camera. Just relax. See that apple of the cheek, enhance it. It will confirm where you want to enhance it for the patient. Relax now. And the other way is use your finger to actually simulate the result you want to create. This is all confirmation of what you're trying to achieve. So from there, I know that most of my product need to be around here, in this region. Okay, let's repeat the same process in this part. Okay. Now, it is important, we mentioned that this patient have tear trough. If you place a product all the way up here, notice what will happen is the tear trough is going to be a lot worse. And we know that the cheek doesn't go all the way up to the orbital rim. So there is a slow, gentle slope from the orbital rim to the apple of the cheek. That's what we want to create. Okay. So having mark the patient. The next thing we want to do is, in this particular case, I'm going to demonstrate how I use the cannula. So you want to place the injection point at least a centimeter from the injection site. Let's come in. Okay, let's zoom in a bit more now, please. Concentrate onto this area. So you can see this will be where my injection point is, at least about a centimeters from it. The other thing that I've commonly seen is people put a lot of product up there, and if you look at most of even a supermodel cheek, there's really not a lot of whitening in that region, and sometimes you create too much width there, and it's not very aesthetically normal to have so much fullness on the cheek area, the zygomatic arch. So once again, we want to place about a centimeters. Okay, so now what I'm going to do is I'm going to demonstrate how I actually do the injection. So before the injection, normally routinely I put them on 500 milligram of Keflex just as a single dose. Sorry, 1 gram of Keflex as a single dose. Just sit up a bit for me. I'm just going to set her up. Lie back for me now. Good. Lie all the way back. So you want to actually make them very, very comfortable. You also want to be so comfortable for yourself when you're doing the procedure, because after all, if you're not comfortable, you can't do it efficiently. Okay. So while we're setting up, we'll get you to move the camera closer to the patient.
Do you want me to take my boots off?
No, let's leave it there. We're just going to get you over and rest it. Yeah, you can rest the legs down now. Okay. All right. So
I'm comfortable.
Good. Come in now, so that your camera is okay. So that your camera is almost straight onto the cheek. Come zoom in now. Good. Too much. Slow down. Slow. Pan out for me. Okay. Now, if you can just zoom in now, so you can see this part. Okay, a bit more. If you can, okay, that's fine. Right, so of course you want to make sure that your hand is nice and clean. The whole process is you want to clean the face of all the makeup as we have done here. Not even the mascara. We want to remove most of those things. That beforehand, and we normally just sort of wipe the skin with some chlorhexidine, the antiseptic of your choice, before I even treat the patient. The next thing is I'm just going to put a small amount of local anesthetic in this patient. And let's give me a blue thing. So, okay. So here we have a chlorhexidine impregnated gauze. That's once again for local anesthetic. So here I have a 0.3 ml syringe. I like to use local anesthetic 1% with adrenaline. That's my preference for two reasons: to eliminate any risk of bruising from my injection site. So I have marked where my injection site, you can see it, and of course you want to not place the product through where your marking is. So just be close. So this is the only uncomfortable bit, and we know that because of her acne scarring, the skin's going to be a little bit fibrous. So I'm only going to use 0.1 ml for this patient. So put some in the skin because that's the way that they will feel the most. And then I slowly, in an anti-grade fashion, gone down to the bone. I have used slightly more than 0.5. So I will move on the other side now. Same thing. Cleaning, small amount of local anesthetic. Do some in the skin, just a very small amount. That's the most painful bit. A little bit more, deeper in the subcutaneous plane, and advance the needle down to the bone. You can feel it, and put some just in that area. Okay. So while I'm doing that, while I'm waiting for the local anesthetic to work, this is the time that I really want to clean the skin. And this is not a sterile procedure, but we certainly want to be absolutely sure that we are as... I need a bit more chlorhexidine. We're absolutely, as clean as possible. So this, once again, is chlorhexidine impregnated, quite a lot of it, and I will tend to, particularly where I know the cannula might be touching the skin, and I'll try not to. I just want to put as much sterility in this procedure as possible. Once again, clean the surrounding skin where I'm going to do it. And while I'm doing that, I'm going to... Okay. So with the modern technology, I believe that in this webcast, you guys can, and I encourage you to send me or email me some questions as I go along. The first question was specifically what complication have I seen, and I believe I've certainly covered that in the lecture. In the last 7.5 years, I have 3 cases. One was the product displacement on the lower eyelid because of my technique of inadvertently penetrate through the orbicularis muscle, and hence with the compression of the muscle, I create a product in the lower eyelid. And the other two cases in the last 5 years has been small nodules in the jawline, which the patient mentioned, but I did not do anything because it doesn't really bother the patient. They just want to know that it's going to be okay. And you know that in those small nodules, that doesn't bother the patient. If you leave it long enough, they will tend to resolve on its own accord. This is obviously different compared to those huge, big nodules that have been referred. Now we just want to concentrate close-up view now before I inject. So if we can just zoom in a little bit more, please, just around here. Okay. Now you will probably appreciate a bit of blanching in this area from my local anesthetic. That's one of the reasons that I use this. Now, I apologize, I'm a Michael Jackson fan. I tend to use one glove. When I inject, I change it to a sterile glove, and the one with the glove is the only part that touches the patient, the sterile glove, and my finger is just an area, it's just the hand that I use to do something not that important where it doesn't touch the sterile part of the needle. Once again, this is more of a habit because of my, you know, I like to be able to have an unimpaired tactile feeling. Okay, so it's important. Now I'm going to use a 21 gauge cannula. It is important to use a suitable size needle as an introducer. There's no point using a 25 gauge introducer or needle and create a 25 gauge hole where you're going to fit in a large cannula or larger cannula. You simply are going to create too much of a blunt force in order to engage that particular small hole. So try to be atraumatic as possible. Try not to force things along. So I'm going to put this down to the bone, and as you can see on your view, there is a 21 gauge cannula through there. And how you feel doing? Good. You okay? Yeah. So big smile for me. Big smile. Relax. Yeah. You can see the needle's moving. So why is the needle moving? Well, two reasons. One, the muscular, particularly the orbicularis, when the contracting is actually moving the needle. So then what I've done, what I would like to do is I want to create a track. So I would aim where I'm going to place the cannula. And this is the bit that I stretch the opening a little bit, as well as stretch the track a little bit to make it easier for me to introduce the product. So let's have the product now. So here we have, let's show the other camera. Here we go. A 21 gauge pixel cannula, and all of you know the orientation, the advantage of it. And the important thing is, you know that when you inject through this, can you zoom in now for me, please, onto the cannula? I'm not sure whether you can see it. Okay, the product just flows through easily with hardly any force. And that's what we want. We want the product to actually come out with minimal force so that it doesn't accidentally being propelled into area we don't want it to be. So we'll take the needle out. And this is probably the hardest part, okay, to finding that hole that you created. Once we've done it, you want to lift up the cheek. So I'll get the patient to move to the left a little bit more for me. Okay. And zoom up a little bit for me. That's a maximum zooming. Okay. Okay, so this is a bit that if you can't get through, you want to do almost like a corkscrew thing, and you will feel the first through. Okay. And okay, you will feel a give because you've actually tried to engage and penetrate through the orbicularis muscle. Now once you do that, and we want to make full use of the fact that you've got a bit of lidocaine in the product, in the SubQ, and then I do a lot of antegrade injection as well as retrograde. What sort of injection you do, it doesn't really matter as long as you place the product right where you want it. So you know that at this stage the patient is fairly comfortable. So with a gentle lifting motion and constantly aware that I'm actually touching the bone and you're advancing it. Okay, how are you feeling, Vanessa?
Good.
Fairly comfortable?
Yes.
Okay. You don't have to say it just because you're on the stage.
Okay.
All right. You can say ouch if you want to,
It's okay.
if you're in pain. So by the way, Vanessa never had this sort of procedure done before.
No.
So this is what I tend to, you can say, do it on a daily basis. This is, you can actually, you just want to do it so effortless and so make the patient feel so comfortable, because if the patient is in pain, you feel pressure to want to finish this procedure so quickly. So once again, I'm actually not squirting a lot, just a very slow, and having a look where you are and advance the needle a little bit closer. So this is where the cannula is, okay? And as I'm doing it, I'm slowly injecting. And okay, I'm not sure whether you can appreciate the contouring that I'm seeing now. So now I'm withdrawing, I'm going for the second track. Still doing a little bit of antegrade injection. Okay, so you just turn to the left a little bit more for now, so you can see perhaps now the sculpting, the lifting of the cheek, creating a very nice cheek mound for this patient. Okay, that's about what I feel is adequate. Just turn towards the camera now. So this is a cheek compared to the other side. Pan out a little bit more for me. So you can see the difference in terms of the projection. Of course, I've just withdrawn the cannula. I have not done any molding compared to this side. Okay, so you can see the nice cheek mount. And pretty atraumatic, a slow process, and I have just used up to slightly more than 1 mil. So if you can pan in now, so have a look at the amount of product on the syringe. I have just passed the 1 mil mark. I'm not sure whether you can see it there. Okay, so I'll pass the product back, and I have a dry gauze, please. So we just want to clean the entry point. Relax now. With this, I'm just going to gradually, once again, there's not much of the pressure required to actually mold and sculpt the thing. And if I can now just clean up the malar. Okay, if we can then pan in now a bit more. Okay, we can see suddenly it's got a slightly rounder cheek area for you. Okay, and also, I'm not sure if you appreciate more is we're creating a little bit of a submalar, favorable submalar shadow. It's created almost like a very, very modern sort of model type of appearance. So now I'm going to go over to have a look to see whether there's any questions that need to be answered. Okay, while we're waiting for that questions, I'm just going to go ahead and inject the other side now. Once again, if we can have another chlorhexidine gauze, please. So as you can see, I really truly emphasize how important it is to actually continue to use a lot of chlorhexidine. I constantly use it to depth, particularly the area I know is where I'm going to introduce the cannula. Now let's have a sharp, thank you. Okay. That's a new needle. I've just been informed. So once again, okay, just zoom in a bit more if you can, where I'm going to place the needle. Okay. You okay? So once again, slowly place it. This is down to the bone once more. We can feel it, and I just want to go and open up that space a bit. Okay. This is a brand new. So once again, I just have a new syringe with primer. So once again, give the area a bit of a wipe. Okay. Now it is important when you do this part, or similar when you use cannula, it is a fairly long cannula, to be aware of where the cannula is touching, because this is the bit that will go into the patient's tissue. It is very important. It is so important for you not to contaminate this area at all, particularly resting on the skin. Okay, so notice that I keep wiping it with chlorhexidine, and once again I'm going to pinch. Okay, I'm in the opening. I'm going to engage the orbicularis muscle. This is where you're going to feel a little bit of resistance, and you're going to feel some a pop or some giveaway. And then once you've done that, you want to put a little bit of a product there just to make it comfortable for the patient. Okay, so this is the part that once you see that the patient's feeling some, you just want to slow it down a little bit. Because it has a lidocaine, it's just within about 2 or 3 seconds, it will numb that area. Once you've got that, that's when you want to go in a bit more. Engage it. How are you feeling now? Okay. So I am do a very slow anti-grade injection, placing the product where I have already pre-marked. Now, it's one of the things that I feel that it is good practice to start marking the patient, because as soon as the patient lie down, the area of volume deficit will appear differently compared to when they are sitting up or standing. Okay, how are you doing, Vanessa? Good. So once again, you can actually do it fairly effortless without creating too much of an issue for the patient. So in this particular patient, this side, I've just used, if we just concentrate on the cannula now, please, on the syringe. So I've used just 1 ml. And on the other side, I've used 1.25 ml. Okay. So for patients who never had any of this done before, I tend to be on the slight conservative side because it's easier for us to come back and replenish a bit more. Let's have a dry gauze now. Okay, once again, I am going to do a bit of molding. And then, when I'm fairly happy with the way things are sitting, I will sit the patient up just to have a look before I fully convince myself that I've completed the procedure. So the next thing I'll do is I'll get you to sit up a bit for me now.
Yep.
Okay. And we will just have to move the camera back now. Okay, so if we can just, no smiling, I know you're very happy. I have to refrain you from smiling now. Just relax a bit for me. Okay, relax a bit on your cheek. Okay. So just lift up your chin a bit for me now. Okay. First thing is, getting old, I have to change my glasses. Okay, so first thing I want you to concentrate now is the cheek has some 3D structure now. The first thing you notice is suddenly there's a little bit of favorable shadow through here, which from my discussion with the patient, that was what we want to achieve. It creates almost like creating a blush, chemical blush type of look. Okay, just relax a bit for me now. So we certainly improve that. Similarly, we've done the same thing on this side. And if we were to look at the patient now on a 3/4 shot, just bring your cheek down a bit. And you can appreciate suddenly from a very sharp straight line, there's now a slightly gentle curve in here. Okay? Just look back a bit more. Oh, yeah. So from where I'm sitting, I feel that it is a little bit flatter here compared to this side. So I will go back to treat this side now just to complete. So following this, I will start treating the tear trough for this patient. So let's complete your treatment now. Just lie back. We'll do a bit of chlorhexidine, please. Just a little bit more. Okay. So sometimes your assistant can be very stingy with chlorhexidine, and you have to get them to be a bit more generous. Thank you. So I really like to basically flood that area with a lot of chlorhexidine. So we will use the cannula again, please. Yep. Okay. So just relax for me now. Thank you. So introduce the cannula back to the same track. Once again, we need to engage the orbicularis muscle. Okay. How are you doing?
Good. I can't feel a thing.
Good. So the patient just said she couldn't feel a thing with the cannula throwing it. So sometimes when you come medially, as you encroach the infraorbital nerve, this is a place that you want to be even slower because they can be a bit uncomfortable as you get medially towards the medial limbus, because that's where the nerve is. So same trick, you want to put a bit of product in there, wait for a few seconds before you place more product. Okay, so that will complete the injection in the midcheek. So while we're doing that, there is a question, how long you wait to place. The question was, how long do you have to wait to place more product if the volume result is less than desired? Are there any problem in doing this? Well, you can place the product. Well, normally, I would, you know, it's just how practical you can. You can, in theory, place a product tomorrow, but most patients will have a slight degree of swelling the next day. So I normally say come back within about 10 days, in 10 days or 2 weeks, and I'll reassess the patient, and that's where I'll place more product in. I don't think there's any problem of doing this. It's something that we routinely, I routinely do it in my practice, and I'm sure a lot of you do it in your practice on a daily, as a matter of routine. So, and because we have introduced a fairly big size opening in the cannula side, if you zoom in now for me, please. Okay, so I like to place a small flesh tone color dressing just to cover it. Okay, just to cover it, just once again, in order to reduce the risk of contamination of that side. And how long do I leave this for? I normally tell them leave it on for about 3 or 4 hours if they can, or overnight if they can, and then take it off before they go to work the next day, just so that to allow sufficient time for the cannula site to heal up itself, because the patient most of the time would like to put some makeup on after, you know, a few hours or a few days. So my routine is I would prefer them not to have any makeup in that region. Now if they really have to, that's when this dressing is very useful. It will prevent any contamination. So I normally say put this on, put the makeup around the dressings, because it's flesh tone. Okay. The next thing is I want to actually get you to zoom in through here now. Okay, just open your eyes up. Okay, so if you look now, this patient, if I can show both sides, please. Okay, zoom out a little bit. Good. So she has a infraorbital hollow and some tear trough here, and come all the way to the lateral orbital rim. So I like to use, in terms of product, in this case, a Restylane Perlane. In this case, corrected. You can use Restylane product if you want to, and that's your choice. I just like a product Perlane in this region. So the next thing is lie back down now. Now I hope that I've managed to answer the last questions fully for whomever who posed that questions. That's been answered. So if there is any further questions, so now we want to concentrate on injection of the tear trough. So once again, the same technique, clean it. I like to actually get the patient to open their eyes. Okay, bring your chin down a little bit. Good. Okay, are you fairly comfortable?
Yep.
Okay, so if you are going to inject tear trough and if you are using needle, and most of the time after you've done the malar injection, part of the branches of the infraorbital nerve has been anesthetized, and that will help. And if you actually do this as a standalone, the best injection point will be at the area of the medial limbus. Just look, open your eyes. Medial limbus is junction between the iris and the sclera, which is right here. You put your finger here, you will feel the infraorbital foramen. Okay, so it's not at the mid-pupil. So that will be the first place that I want to place a product, because if I put a small amount of product there, okay, they will feel the needle initially, relax, okay, and I just put a small product there and wait. Get you to open your eyes for me. I like them to open their eyes so that it will delineate the area a bit better. So once I've done it, I'm still going to advance it anti-grade, staying deep. And that's it. Okay? And then do some gentle molding in that area. Okay? Right. And then once we've done that, we're just progressively moving a little bit more laterally, once again, going from low, feeling the bone, and then put a small drop of product, and constantly get the needle moving. As I'm injecting, I'm moving towards my previous injection site. Slowly, slowly, slowly placing the product. Okay? Gentle molding. Relax a bit for me now, thank you. And I can see, I just want to have a look at the monitor now. Good. And just look straight into the camera now. Good, relax a bit for me. And I'm not sure you can appreciate the dark circle and slowly being softened and erased. So the next thing is, so past that point, that's an area not supplied by the infraorbital nerve. It is supplied by the zygomatico-facial. Now the fact that we put a small amount of product here, hopefully it will reduce the discomfort, but most of the time they might still feel a little bit of a tiny little prick in that region. So once again, let's see. Okay, down to the bone, and lift up the soft tissue and inject along the bony margin in an anti-grade fashion. And I found that that's the area, the lateral margin is the place that I tend to use a little bit more product, simply because this is where the muscle, apart from here, is tightly bound to the zygoma. You find that you tend to use a bit more product in that region because it's fairly tight. It doesn't get a separation in that area that easily. Okay. You're doing very well. How are you doing? You okay?
Yep.
Yeah. Okay, relax a bit for me now. So what I'm trying to do now is trying to improve that demarcation between the eyelid and the cheek. So once again, we want to go in there and go straight down to the bone, and then lift up the soft tissue like what I've done there, knowing exactly where you are, and slowly inject anti-grade fashion. So tear trough region is an area that I tend to not fully correct because there will be a very small amount of post-injectable swelling. Okay, now, okay. So if we can now compare to the other side, please, both sides. Okay, zoom in a bit more. Okay, you can just appreciate the deep hollow, the dark shadow. Come in a bit more, come in a bit more, more. Keep zooming in to under the eyelid. Good, okay. Good, perfect. You can see that how much improvement we've created to soften up the shadowing, the hollowing in the infraorbit margin, to blend the eyelid and cheek junction. Okay, so I'm now going to go to the next side. I'll change the needle first. If there's any other questions, please feel free to email us the questions. Any other questions? You have to bring it out for me, I can't. Okay. So once again, for those of you looking at the screen, I'm just putting a small amount of product just at the level of the infraorbital, at the medial limbus. Okay, I'm just going to let it sit for 5 seconds because that's where the branches of the nerve is. So Bernice, I'll get you to have a look at the screen because I'm back to the monitor. I can't just make sure that the audience can see my injection. Yeah. How are you doing now? Okay. Okay. So if you just do it slowly and allow the product to anesthetize the branches of the infraorbital nerve, now it will be a lot more comfortable. So I'm skirting along the orbital rim just to improve the tear trough. You can certainly do the the tear trough with cannula, but it's an area that I have now moved back towards the use of needle because I have not seen, I'm fully convinced at least, that it reduced the bruising that much in this area, and I found it's a bit more difficult to get into the correct plane with cannulas. Okay. And just to finish off, we just come from the lateral margin on the bone and lift up the muscle and just inject as I go along. And for those of you who have heard Marco Kane, this is where he talk about that V-shaped thing, and it's actually not a bad idea to put a small amount of product in this region, deep, just to efface that. Okay. So. No, I'm good. I just need a dry gauze, please. So the next question, was, how many cases have you had complication with patient that you have treated not referred to you for second? How many? I actually don't understand. Do you understand the question? How many? The question was, how many cases do I have come with patient that you have treated, not referred to you for second opinion treatment? So how many of my patients treated that's been gone to somewhere else for complication? I'm going to be quite cocky here. I would have thought that I do have a very good rapport with my patient. I actually insist to see every single cases of my patient whom I have treated personally, and I am pretty convinced that almost all of them will come back to see me if there's a problem, because they get to see me at about 2 to 4 weeks after the treatment, and they know that, you know, to at least call us back or come back to see me. So what percent of cases might expect issue post-treatment? Well, there is no such thing as a ideal product. As I have shown you before, some of the complications are technique related, which we as an injector just have to be improve our technique and learn from our complication. From the product itself, well, I can't really pinpoint. I've had 3 cases in the last 7 years, and if in all the 3 cases, I have to say that they are all technique related. I'm aware of some cases of perhaps granuloma formation, and that's almost certainly, you know, we don't know what's the cause. It could be a subclinical infection, but we also know that there are some immune-related complications that no one have the answer for it. But I can say that categorically, we know that every single product, particularly those slightly long-standing, will have some of those problems, but it is by far extremely low. It will be in the vicinity of, you know, less than 1%. So if we can go to the next questions. Do we have another questions? While we're waiting, Bernice, I'll get you to clean the patient. So we had that question before. Can we move on to the next one?
Yeah, sure.
Now that I have some time, can I pick it myself now? Or
Yeah.
can I?
Let me just.
We'll just show it to you in the camera.
Which one did you get to just before? Did you go through them as well? Just scroll down.
Okay. Okay. So. Okay, the next, how do I select?
Which one?
I want to select this.
So you go like this,
Okay,
and then you just hit refresh,
okay,
and then show the question. There you go.
okay. So the next question is, when pushing SubQ, is it antegrade or both antegrade and retrograde? With antegrade, is there increased risk of complication? Okay, I've answered the last bit. No, antegrade does not increase the risk of complication on the proviso that when you inject, you're not really putting all the force into the plunger and trying to get the whole syringe in one push. I think whenever it comes to injection, your right thumb will be your, the most important tool you have. It controls the rate. My injection technique is always tend to be a fairly slow, continuous flow. So I do not believe there's any difference between antegrade and retrograde. I like antegrade because, as you can see, I use very small amount of local anesthetic, and I'm relying on the local anesthetic in the product to anesthetize the area before I actually push my cannula through. So basically, I'm constantly putting a small volume of SubQ with lidocaine in front of my cannula so that the area is already numb before the cannula reaches there, so that become very, very comfortable for the patient. And then, of course, when I withdraw the cannula, I also put some retrograde fashion so that I am being quite efficient in my movement, so that I can do this with minimal stroke and minimal passes. let's move on to the next questions. Okay, the next question is in why do I choose Perlane over Restylane for the tear trough? It's a very good question. I think it comes down to personal choice. Perlane, of course, is a little bit firmer than Restylane, and my personal feeling is perhaps with the increase in cross linkage, it also perhaps reduces the degree of swelling. But if you're going to use Perlane, we know that it's a firmer product. You've got to make sure you place it very, very deep right on the bone. There's no reason why you cannot use Restylane for this area. You can certainly do it, but you know, it's just a personal preference. There's really no difference in longevity. But I will not use Restylane SubQ in the tear trough for the reason I mentioned before, because with a high G prime, with a larger molecule, you really cannot get away with it with so little amount of soft tissue covering the tear trough region. The next question is, do you think you ever inject products superior to the orbicularis retaining ligament, and do you think it's better? The answer is yes. In some patients, I do inject it more superficial to the retaining ligament, that is within the muscle. And the reason being is, of course, you know, Michael Caine has taught us that he routinely injected. He felt that is just underneath the skin. My feeling is it's almost impossible to do it under the skin. You probably place a product in the superficial layer of the orbicularis muscle, closer to the skin. That really does not matter. The matter is you can get away with it, and all you got to be absolutely sure is you actually almost place no product there. You're placing 0.001 amount of product. And I do that for patients who have significant soft tissue laxity, where you know that by placing it deep, you can improve most of the tear trough, but there's still some laxity and some deficit in the superficial component. Those are the ones that I will go in the superficial plane. But it's something that I will not recommend for beginners, because I think if you are not that experienced, you may place too much product and creating lumps, Tyndall sign, and product visibility. Yes, the next question is, can you use cannula for the tear trough? The answer is, of course you can use cannula in the tear trough. I certainly has done it in the past, and I certainly continue to use it for those patients where the patient presented with a dark shadow under the eyelid, not because of the true tear trough, because they have an anatomical protrusion of the orbital rim, where I use the product. If you think of it almost like using, putting a layer product along the bony margin to push the bony margin forward, almost like doing a bone grafting, but I use it with cannula. But for a common variety tear trough, I tend to use a lot more needle, simply because I feel that I can do it as efficiently, perhaps faster, more precise with the needle, and create the same amount of bruising whether I use needle or cannula. So hopefully that answers your question. The bottom line is, it doesn't really matter whether you use a cannula or needle. The most important thing is you've got to be absolutely sure that you are getting the product where you want it to be. There is no point of using cannula if you believe that you can cause less bruising but not producing the optimal result. At the end of the day, you still want to produce an excellent result, even if it means that you give the patient a bit more bruising, because I think the patient will be ultimately more forgiving if you create a bit more bruising but give them the result that they wish for, rather than no bruising and get a suboptimal result. Okay, so the question was, one of my nurses have to have 5 doses of hyaluronidase and may need more. Am I just unlucky? One side had to be drained percutaneously. It was sterile. If you can just pose me another questions, I'm not sure what complication you're referring to, whether you're referring to a nodules, a hard lump, or whether there's actually a frank abscess. And for that particular person, if you won't mind, pose that question to me again and try to make it a little bit more specific, telling me exactly what the problem was, whether it was recurrent swelling, recurrent nodules, or recurrent infection. Okay, the next question was from Melbourne. Question 1, what did you find when you perform open drainage? So what did you find when you perform open drainage? Well, when I perform the cases that I've performed open drainage, there were frank pus in one of the patient, and in the bottom of it you can of course see some of the product within the pus. In patient where I have to put a needle through, you can actually feel that it gone through a layer of thick fibrous tissue. And that's why I know that in those patients, unless you put the needle straight down within the lesion and get the product out, even if you squirt a large amount of hyaluronidase, you're not going to dissolve it for that reason. And the next question was from the same person in Melbourne. Do you think that all SubQ placement encapsulate? Otherwise, how does it maintain its form? Okay. No, I do not believe that all SubQ placement encapsulate. SubQ placement encapsulate if you put a big bolus of product in one area. If you put a micro droplet of product or tiny little track of product, it doesn't get encapsulated because you will get a vascular ingrowth or tissue ingrowth within the product. You will only get a SubQ encapsulation if you put a big block of product into one area, simply because the product lasts a fair amount of time, and as you know, with inflammation you will lay down a little bit of collagen, and you have a lot of foreign body there, you create a foreign body reaction. Let me just move down. Okay. Do you recommend changing the cannula between the two sides? Now, I know this is certainly the recommendation from the company, but I don't know the answer, but I know that I don't do it in my office. You just have to be mindful of where you put the cannula. So you can't see the setup with here now. All the patients who have SubQ, we open up a dressing pack, and I also do not place the cannula directly on the dressing pack. I tend to put it within the sheath of the cannula to maintain sterility, because if for some reason you may accidentally contaminate your dressing pack. So that's That's why I don't change it. Of course, if you inadvertently touch a cannula, you should change it because you contaminate it. If the patient has a thin, empty skin, what is recommended? If the patient has very, very, very thin skin and subcutaneous tissue, I would in those cases use Perlane rather than SubQ, because even though you can get away with it, you might see a sort of the edge of the implant rather than a smooth transition. The next question has been okay, what prophylactic dose of Keflex? I use 1 gram. There is no empirical study to support it, and the reason I use this is we know that with any surgical intervention, be it a simple gallbladder, a clean gallbladder removal, or a large cutaneous lesion, excision, a 1 dose of prophylactic antibiotic has been shown to reduce post-operative infection. Now, I know that this is not an open procedure, but I feel that by giving a foreign material into the human body, and I know that the product do last a significant period of time, and I look at this as almost like doing an open procedure, hence I give them 1 dose of prophylactic antibiotic. But you're quite right, there is no empirical evidence to it. Yeah, so why do I continue doing so? Because for the reason that I've mentioned before, I just look at this as some sort of a foreign body material. I just want to eliminate the risk. Okay, how much post-treatment swelling are you likely to experience? For this patient, I will not envisage her to have a lot of swelling, simply because 2 things. We know that the hyaluronic acid is hydrophilic. It will absorb a lot of fluid, but not Restylane SubQ. And the second thing is, I believe that I've demonstrated to you a very atraumatic way of doing the procedure with gliding of the cannula with minimal force through a plane where there's minimal resistance. The only resistance that I have shown you that I have encountered is when I push the cannula through the orbicularis muscle. The rest was basically through a very loose areolar tissue. There's a nice surgical plane there, so I do not envisage a lot of swelling. What do I think of the longevity? I think that patient was starting to come back to see us at about 9 months, but if you are truthful, you have a good photography, you'll see that most of them still have the product. So how long do I think? I think they last for about 12 months, but patient will feel that they have lost most of the product because they got used to most of the bulk of the product. So I'll tell them 12 months, but I routinely get them to come back to see me at about 8 to 9 months to see whether they need a second treatment. I'm going to choose the last questions, if that's okay, Richard? Yeah. Let me just see whether, in fact, I've actually answered most of the questions. Okay, the last question is actually very good. How do you minimize shelf appearance of the lower orbital rim when injecting cheek in the lean tissue, in the lean patient? These are the patient when you inject the cheek, you don't want to inject too much product. I will put the main bulk of the product a lot lower than the infraorbital rim, just like what I've demonstrated, because there's not a lot of fullness in the infraorbital rim or directly at the infraorbital rim. You always have a slight gap and then gradually move on to a slope into the peak of the mound. So I would put most of the product at least about 2 centimeters away from the orbital rim, so that you get a gentle slope to that area. I hope that answered most of your questions. Because of time issue, I'm going to stop the webcast now. Hopefully that answered most of your concern, and hopefully that the demonstration as well as what my personal experience have debunked some of the concerns and some of the myths that, oh sorry, I meant to look at this camera, debunk some of the myths and some of the concern recent SubQ, because it is a highly versatile and effective product in creating a very nice sculpted cheek. And if you place it in a deep plane, in an appropriate plane, you can create a nicely sculpted and soft appearance. And if I can just show you what Vanessa is now, and she's been here quietly listening to the conversation. If you just look at the camera now, if we can zoom in as much as possible. Okay, this is her about 40 minutes after the injection. And if you look at her now, apart from this small dressing in there, and despite the fact that we do multiple puncture and tear trough, dare I say that she can really, you know, go to dinner tonight looking good with no telltale sign that she had treatment. And relax for me now. You have to stop laughing. I know you're very happy. Just relax. You can see, you know, the fact that this product is deep. Sure, you can feel a little bit of firmness now because this is immediate. And she still have this a fairly soft appearance, and she has a sculpted cheek. Okay, there's nothing sharp about the face anymore. So to answer your question, how much swelling, I would think that she would have a small amount of swelling tomorrow, and that will only enhance her appearance because she will have this glowing appearance when she goes to work tomorrow. So I hope that answered most of your concerns, and get rid of most of your fear in using this product, because I really, really do not believe all those fears are founded. If we use a proper technique, do what the product's been designed to do, use the appropriate size cannula, be very rigid and be very, very, very cautious and anal with your way you sterilize, use the chlorhexidine. Okay? Good night to you all. Thank you so much.